Now we will be moving on to our first section, that is the complication of leprosy in hand. As you know, it is actually infection of a Mycobacterium leprae in which the multiple gummas are formed, it's loin-like facies, but it specifically affects as it's a neuropathy, it affects the nerves of the hand. We'll be briefly discussing what is a claw hand and what are the claw fingers, it affects the thumb in ulnar nerve palsy, and what is triple paralysis, that is the loss of ulnar, median, and radial nerves. So in hand, what happens is, as you know, it's due to the peripheral nerve abnormalities. It's kind of a peripheral nerve lesion, and it's usually the most commonly affected nerve is the ulnar nerve. There is a loss of sensibility and muscle weakness. The hand in the leprosy, the most commonly, as I told you, is the ulnar nerve. Ulnar nerve is mainly C8T1, so it is the most important fact is always on the ring finger and the little finger. Usually, the sensations are lost on these ulnar 1.5 digits. There is maybe a loss of sensation over the hypothenar eminence as well. There is degeneration of hypothenar leading to hypothenar atrophy, along with the formation of claw hand. What happens and what type of different patterns of paralysis can be seen is clearly visible in this table. It could be an isolated ulnar nerve injury, which is usually the most common, and it could be high or low. As you know, with the ulnar nerve injury, there is a term called as ulnar paradox. Instead, if it's a high ulnar nerve injury, there will be less clawing as compared to low ulnar nerve injury. Therefore, this ulnar nerve paralysis is most common, which results in a partial claw hand or ulnar nerve palsy or Z deformity, which is usually seen as well. There is loss of intrinsic muscle deficiency with positive Froment sign. Problem is with the poor precision handling and a weak grip. Although the median nerve and radial nerve are functioning, therefore patient can pinch or at least make some movements with the hand. But although the grip is possible, but it is actually weak because the ring and the little finger are not working properly. Now it could be a combined ulnar and lower median nerve injuries. Although it is less common, but it can also be possible because this can affect the median and ulnar nerves as well. And there could be a total claw hand or claw fingers or even a claw thumb. This kind of deformities could be present, as you know that usually this thenar eminence, the radial 2 and 3.5 fingers area is supplied by the median nerve, and ulnar 1.5 finger is supplied by the ulnar nerve. So there could be atrophy of thenar and hypothenar. There could be loss of intrinsic muscles. There could be the paralysis of FDS of all the 4 digits and FDP of the index and the middle finger. This could lead to probably the problem with the pinch as well. The patient will not be able to pinch or grip properly because now the median nerve and ulnar nerve both are damaged. But there is some degree of power grip and precision is possible with the patient is able to carry a briefcase with this maneuver at least. And the third option is could be ulnar nerve, low median, and radial nerve paralysis. Although it's a very rare one, it usually results in a drop wrist and drop digits because now there's a median nerve paralysis along with ulnar nerve and this combined radial nerve injury as well. Now this loss usually when all the 3 nerves are lost, this leads to severe loss of function and patient cannot grip or hold objects. There is another form of injury it could be, which is also very rare. It is combined ulnar and high median nerve palsies, or it could be high ulnar, high median, and radial nerve palsies. That is, it is affecting the nerves, all the 3 nerves up in the arm. With this kind of injury, when it's a triple involvement, that all the 3 nerves are involvement, usually there is total loss of function below the elbow joint, and this could lead to a flail kind of a four-limbed hand. Now, if claw fingers are present, how to correct them? As you know, if you see this diagram of the hand, this ulnar 1.5 digit is supplied with ulnar nerve and as with the hypothenar eminence. The FTP of this ring and the little finger is actually supplied by the ulnar nerve. Therefore, if this is the lost, this results in the flexion at the distal interphalangeal joint and proximal interphalangeal joint is not possible. Therefore, this leads to kind of a clawing of hand, which is usually seen with ulnar nerve palsy. The correction, as you know, if it's only ulnar nerve palsy, median nerve and radial nerve are intact, then we can correct it by rebalancing the muscle pull at metacarpophalangeal joint and proximal interphalangeal joint, which is the most important part at this level and at this level. And we know at proximal interphalangeal joint it is the FTS insertion, and at the distal interphalangeal joint it is the FTP or flexor digitorum profundus insertion. So the option is Lasso's operation of Zancolli. It's kind of making basically a tendon of FDS is actually split up into 4 slips. A slip each is actually looped around the A1 pulley. As you know that A1 pulley is at the metacarpophalangeal joint at this level. Then you have A2 pulley and A3 is at the proximal interphalangeal joint. Therefore, we have during at this A1 pulley, the FDS is actually brought back and looped around the A1 pulley so that it can regain its function. Lasso is actually making it's called as making a loop or a pulley around something. Therefore, that is why it is called as Lasso operation of Zancolli. Other option is if there is a thumb problem, although thumbs would be intact because it's mainly supplied by the muscles which are formed on the median nerve. But if there is associated ulnar palsy, what could be the deformities which may also be present or may be seen in case of leprosy hand with median ulnar nerve palsy? This could be due to flexor pollicis brevis paresis, and it can be problem could be at the flexion at a metacarpophalangeal joint. There could be extension and interphalangeal joint. As you can see it over here, there is metacarpoflexion and extension and interphalangeal joint. Or there could be this could be other option could be is dorsalizing the flexor pollicis tendon. Now flexor pollicis longus would actually causes the flexion of the thumb and it's just at the distant interphalangeal joint, but this can be dorsalized so that the claw hand can be corrected in case of ulnar nerve palsy. Turning the other option could be turning actually flexor pollicis longus into a metacarpophalangeal joint flexors. This can also be done, but different options are available depending upon the surgeon's preference and the techniques he or she is actually able to utilize. Different surgeries can be performed. Another option could be flexor pollicis brevis, which can be transferred to the radial half of the index finger as to act as a superficialis tendon. Now coming to if it is a combined ulnar and median nerve palsy, so both nerves are involved. So the mainly it is actually the thenar as well as the hypothenar muscles both could be damaged. This could result to the paralysis or complete paralysis of thenar muscles. There will be loss of effective power and grip. Patient stabilization of carpometacarpal joint becomes very important because at this level, although all the FTS are involved and all the FTPs are involved, because and they are of all the 4 fingers as well as of the thumb are involved. So therefore, this is important that the stabilization of carpometacarpal joint is imperative. This could be this median nerve involvement, so there will be loss of opposition. The thumb cannot be taken towards the little finger. Though opposoplasty can be used if flexor superficialis is intact, then we can use oponoplasty using a flexor superficialis of the little finger. Otherwise, it could be that extensor indicis proprius, which is actually supplied with the radial nerve, can be utilized to cause so that the opposition of thumb can be re-achieved. Then coming to the triple paralysis, that is the loss of median, radial and ulnar nerves. This is usually, as I told you, combined ulnar and median nerve function and radial nerve function. Severe disability, and it is called as the flexor driven hand because usually there is wrist drop, there is finger flexion, as well as loss of almost all the thenar and hypothenar muscles. FTP, FDS, all are paralyzed. Therefore, usually it's a very severe disability, but it can be corrected with these kind of procedures, or sometimes splints can be used, in which could be dynamic splints which can cause extension of the wrist joint and keep fingers partially flexed so they remain supple and joints remain supple. Therefore, the contractures of joints do not develop over time. There could be other option could be multiple tendon transfers for stabilization, but although we know that actually the forearm is being supplied with these three nerves. So sometimes when there is a massive loss of in case of a high ulnar, median, and radial nerve injury, all the muscles below the level of the elbow are paralyzed. So therefore sometimes very even difficult to find a right muscle for the transfer. But if some of the muscles are intact, they can be used for the transfer, so that the some amount of function with the pinch and grip can be at least restarted at the level of the wrist and elbow. Intrinsic zero hand correction may be required, but also it's depending upon whether it's possible or not, and what whether muscles are available for correction or not. That is actually determines whether the intrinsic zero hand correction can be done or not. In this section, we have briefly gone through the complications of leprosy in hand. Depending upon the which nerve involves, as you know, the most commonly it is the ulnar nerve, which will cause the claw hand or claw fingers. If it is on isolated ulnar nerve, then we can use the muscles which is supplied with the median, the radial nerve for the correction of the claw hand or claw deformity. If it's involving median nerve and ulnar nerve, then as the radial nerve is intact, we can use the extensors of the forearm and the wrist so that they can be transferred towards the flexor compartment, and flexion can be achieved at the wrist and at the finger joints. But if it is usually involving the triple nerves, that is, all the three nerves are paralyzed, although it's sometimes only we have to use the dynamic splint so that at least some degree of movement is being carried out passively at the joints, so that the joints remain supple. But usually, as all the nerves are involved, there are not really a lot of muscles available for transfers. So it's a very complicated situation, and we have to eventually manage with the splints in a long term way. Thank you very much. Keep watching sqadia.com.